Welcome. I am Terry Tropin, and today I'm presenting a lesson on ICD-10-CM coding for myocardial infarctions. Let me start with information about myself. I have a master's in healthcare administration informatics from the University of Maryland Global Campus and have RHIA and CCSP certifications. Also, I am an AHIMA-approved ICD-10 trainer. I have taught health information technology at Montgomery College in Maryland for over 20 years. I also have written books on coding. These books are study guides that summarize the coding guidelines, translate them into real English, and then summarize them. My books include one on E&M coding, ICD-10-CM coding, ICD-10-PCS coding, and external cause codings. These are available on Amazon. Here are the questions you need to ask to give you the information to select the correct code for myocardial infarctions, MI, in a specific case. Was this documented as an NSTEMI or STEMI? Was this documented as a specific type, 1 through 5, of myocardial infarction? Which tissue was involved? Is this the patient's first MI? Are any complications documented? And finally, what other codes might be needed? I will talk about each of these questions. So first of all, was this documented as a STEMI or an NSTEMI? Myocardial infarctions may or they may not, sometimes they are, sometimes they're not, described as STEMIs and NSTEMI. A STEMI is an ST elevation myocardial infarction, and NSTEMI is a non-ST elevation myocardial infarction. You can see from the picture, in a STEMI, a coronary artery is completely blocked off by a blood clot. Let me get my pen. There we go. See right here. Nothing's getting through. As a result, virtually all of the heart muscle being supplied by the affected artery starts to die. In an NSTEMI, the artery is narrowed but not completely blocked. Some blood can get through. Let me point out while I'm here this notation at the bottom of the slide. This is where this information is found in the coding guidelines. You will see this throughout the presentation. So here's another look at what's a STEMI and an NSTEMI. The STE part of STEMI and NSTEMI refers to ST segment, which is seen on an EKG. You can see that here. In a STEMI, the area at the arrow is elevated, while in an NSTEMI, it is not. The MI part of the term, of course, means myocardial infarction. So that's a STEMI and an NSTEMI. So guidelines for coding STEMIs and NSTEMIs. These apply in category I-21, I-22, and I-23. The guidelines state that if a patient has an NSTEMI, which then evolves into a STEMI, use a code for the STEMI. So if it's only partially blocked and then it becomes completely blocked, becoming a STEMI, you're going to code it as a STEMI. If an NSTEMI evolves into a STEMI, use a code for the STEMI. If a STEMI converts to an NSTEMI following therapy, use a code for the STEMI. So the crux of this is if a STEMI is present, documented in the case, somewhere in the case, you're going to use the code for the STEMI for the worst condition rather than the lesser NSTEMI. An excludes to note under the codes in the category I-21 state. Excludes to, meaning not included here. Old myocardial infarction. I-25.2, post-myocardial infarction syndrome, I-24.1, and subsequent myocardial infarction, I-22. So this means that if the circumstances merit, you'll code the I-21 and one of these excluded two notes. Note that I-21.0.3 is a STEMI, I-21.4, 2.A is an NSTEMI. There's also an important note under the code category I-22, which is used for subsequent STEMIs and NSTEMIs. This excludes two note means that codes in category 22 can only be used if the myocardial infarction, the MI, is documented as a type 1 or unspecified. So if it's a type 1, you use this code. If it's a type 2, type 3 to 5, and we'll talk about that more later. So I-22 is only used for a type 1 or unspecified. So the next question is, what is the type of myocardial infarction? This is very important. As we saw in the previous slide, if it's type 1 or unspecified, you use one code. If it's a different type, you use another code. So here's a brief summary of what the difference is. A type 1, spontaneous myocardial infarction due to a primary coronary event like plaque rupture of the stuff in the artery that's closing it down or partially closing it. It may be a STEMI or an NSTEMI. Type 2 is due to ischemic imbalance such as a coronary vasospasm, anemia, or hypotension. Type 3 is a myocardial infarction that resulted in sudden death when biomarker values are unavailable. So this was a surprise. The biomarker value is an indicator that there's a problem, that indicator that might be measured, such as blood pressure, heart rate, x-rays, that kind of thing. There's also a type 4A, 4B, and 4C. 4A is associated with percutaneous coronary intervention within the last 48 hours. So something was done, the coronary artery, within 48 hours, and because of that, the patient had an MI. Type 4B is MI associated with thrombosis and a coronary artery with stent. So there was a stent placed, and now there's a thrombosis related to it. Type 4C is myocardial infarction associated with restenosis of coronary artery after percutaneous coronary intervention, such as angioplasty with stent. So you'll see type 4A, 4B, and 4C all have to do with a procedure and then a myocardial infarction following that. Type 5 also includes post-procedural condition, MI associated with coronary artery bypass graft, a CABG within 48 hours. So the patient had a CABG and then had a myocardial infarction. So one more type of MI is an old or healed infarction. A myocardial infarction is considered old after 28 days, meaning 4 weeks. No additional treatment is needed. So that's what an old one, it's done, it's finished, it's been treated successfully. It might also be used if a patient had a myocardial infarction but did not know it at the time. Sometimes they'll do an EKG or other test and say, hey, you know what, you had a mild myocardial infarction. It might also be used when there's a subsequent MI, and this will be discussed later on. What tissue was involved? So we have codes for anterior wall, inferior wall, transmural, and endocardial. So on the right, you see the anterior wall, the inferior wall. Transmural is, here's the ventricle, so it goes all the way through. The ventricle wall, subendocardial, it goes through partway through the ventricle wall. So far, type 1, STEMI, I-21.0, I-21.3, the fourth digit in the code will indicate the type of tissue, anterior wall, inferior wall, and then other sites or unspecified site. The fifth digit will indicate the specific coronary artery, left main, left anterior descending, left circumflex, whichever. So it's not enough to know which wall it is. You need a specific artery. For type 2, I-22.0, I-22.2, the fourth digit indicates the tissue, just as in the type 1, anterior, inferior, other sites, unspecified sites. However, there's no fourth digit to indicate which coronary artery in these cases for type 2. So for type 1 NSTEMI, I-21.4 and I-21.9, there's no digits for the site. For types 2 to 5, I-21.A, there's also no digits for site. So some of these will say which tissue is involved and some of these will not. Some sites indicate using inclusion terms, not specific digits. So the terms listed under a code, but not through a digit. For example, I-21.09 and I-21.19 both include inclusion terms for transmural infarction. Also, I-21.4 has an inclusion term for subendocardial infarctions. And you can see here again, subendocardial, partial, transmural, all the way through. Why this is important will become in another slide. So here's some guidelines. Do you code by STEMI? If sometimes that documentation may overlap for several different codes, including information about STEMI and NSTEMI, type and site. And here are the guidelines for that. If the documentation states type 2 to 5, STEMI or NSTEMI, use the code for type, not the STEMI or NSTEMI. So that would be from I-21.A with an additional digit. If the documentation states non-transmural or subendocardial, but provides a site, a wall, or an artery, code to the site, not STEMI or NSTEMI. For example, if the documentation states acute inferior endocardial myocardial infarction, STEMI, you're going to pick up on subendocardial, not STEMI or inferior wall. You're going to code it by subendocardial or non-transmural, and you're not going to code use additional code. So like pick one. So non-transmural and subendocardial are more important than whether it's a STEMI or an NSTEMI. So let's do a practice. If you want to play along, pause the video and code this yourself, then turn the video back on to check your work. So acute subendocardial infarction and STEMI initial episode. The code is I-21.4. So in the alphabetic index, you find infarction, myocardium, subendocardial, acute, non-transmural, or non-essential modifiers. And this refers you to I-21.4. Remember, subendocardial takes precedence over the fact that it's an NSTEMI. Be careful using the index. It can be really confusing. If you look up infarction, myocardial, subsequent endocardial, you end up I-22.2, which is incorrect because this was initial episode. The next question is this the first myocardial infarction this patient has had, or was there a previous one? For type 1 or unspecified MI, the coding depends on the timing. Timing is everything. If the first myocardial was 4 weeks or 28 days or less, use a code from I-22 for subsequent MI and I-21 for the first one. This applies even if the patient was transferred to another setting. It doesn't matter. It just matters what the time period was. If the initial myocardial infarction was more than 4 weeks, use a code, aftercare code Z48.812 if treatment continues for the first one, or a history code I25.2, old myocardial infarction, if treatment has been completed. So you're still coding for both, but which code you use depends on how long it's been between the myocardial infarctions. So that's for type 1 and unspecified. What about the other types? For type 2, the guidelines say use I21.A1 for both the first and the subsequent. For type 4 or 5, use code I21.A9 for both first and second. Note there's no subsequent code for type 3, which is sudden death. So here's another practice. Again, listen to the question and then pause the video if you want to code it on your own. An NSTEMI occurred 24 days following a previous NSTEMI that was treated during a prior admission. Patient was seen for the new NSTEMI. First, what is the reason for the admission? Was the patient being seen for the first one or the second one? And then how old was the first one? NSTEMI occurring 24 days following a previous NSTEMI, you code I22.2 for the subsequent NSTEMI and I21.4 for the first one. Since the reason for the admission was the subsequent MI, you do I22.2 as the principal diagnosis and then I21.4 as the secondary. An I21 code must accompany an I22 code to identify the site of the initial acute myocardial infarction and indicate the patient is still within the 4 weeks time frame. Be careful to differentiate between STEMI and NSTEMI. That can be really confusing and easy to get mixed up. Okay, so the next question is, are there any complications? Usually these are complications of an NSTEMI or a STEMI are coded with codes from category I23, which is certain current complications following STEMI or NSTEMI. And there's a non-essential modifier within the 28 days. So it's assumed 28 days. So coding for complications depend on the admission. What is the reason the patient is being seen? If they're seen for treatment of a complication then it depends on, is it the same admission or a different admission as treatment for the myocardial infarction? If it's a complication of the first MI, same admission, code I21 code and then I23. If it's a complication of the second myocardial infarction, I22 and then I23. So the myocardial infarction is first and then the fact that there's a complication. On the other hand, if it's a different admission, if the patient was seen, the MI was treated, they were released, and they come back with a complication, admitted again, you code the complication first and then a code for the first myocardial infarction or a subsequent one. So timing, again, is everything. Just like the 28 days, complication is very important. So complications for I23, the complication must be specifically tied to the MI. If this is not clear, ask the physician. So here are some possible complications. I23.1, atrial septum defect. This is the atrial septum, ventricular septum defect, that's here, thrombosis or a clot of the atrium, arterial or auricle appendage, that's here. And here's some more complications. Some of these are confusing, so I decided to talk about each one separately to make sure we understood what they were talking about. Must be specified as a complication, I-23.0, hemopericardium, blood in the pericardium cavity. Here's the pericardium, the membrane around the heart, and blood can form between the heart and the pericardium. There's also a code for rupture of the cardiac wall without hemopericardium. So it ruptures, but fluid does not collect in the pericardium. So again, we have some more. Rupture of the chordae tendineae, that's the heartstrings, and that's here. And it kind of helps with the function of the valves, and then the papillary muscles are connected to the chordae tendineae. So these can rupture during a heart attack, and that's another complication. So finally, we have two more, I-23.7, post-infarction angina, which may or may not be linked to a specific cause. It's I-23.7, and then of course there's one for other complications, I-23.8. Another possible complication is post-myocardial infarction syndrome, or Dressler's syndrome. This is the type of pericarditis that occurs after a myocardial infarction and can be coded with codes from I-21. So you can see there's an excludes to note, so you can do an I-21 code and an I-24 code for Dressler's syndrome. It cannot be used with atherosclerotic heart disease. So what other codes might be needed? Wow, we've seen a lot of codes, but there might still be others. Sometimes chronic total occlusion and acute myocardial infarction are in different coronary vessels. And as you can see, there's lots of vessels out here, and there can be different blockages. So I-25.82, chronic total occlusion of coronary artery, can be used in addition to myocardial infarction code. It must be a chronic occlusion and must be in different vessels in order to use these two codes. What other codes might be needed? Well, here's some other possibilities of list of risk factors for an MI. And the note under categories I-21 and I-22 state use additional code under these categories for exposure to environmental tobacco smoke, history of tobacco dependence, and tobacco use. So you see a pattern here, smoking, very bad. Another possible code is Z92.82. This code is used when TPA is administered to a patient, and it helps dissolve blood clots. This is a life-saving medication, but it must be administered within approximately 3 hours of the MI. This code is used only if the patient was given TPA and then transferred to another facility within 24 hours of administration. This lets the receiving facility know the medication was administered. Some additional codes can be used with specific types of myocardial infarctions. For type I-21A2, type 2, there's a note, code first underlying cause. You see I have listed again the definitions of the types. So it's MI caused by ischemic imbalance, anemia, hypotension, etc. For type I-21.A9, type 3 to 5, notice that 3, 4, and 5 are all under A21.A9 inclusion terms under that. There's a note, code first if applicable, post-procedural myocardial infarction. So if it's a complication of a procedure, you go to I-97. Code also complication if known and applicable, T82. Code also complication, cardiac arrest due to underlying cardiac condition, I-46.2. So as always, pay attention to those notes because they can give you a lot of really good information. So finally, notes to make in your book. Nobody can remember all of the guidelines, so it's really important to write stuff in your book. So go to the alphabetic index and look up infarction. This is almost a whole page, so if you can divide it up, that will make it easier. Note that under infarction are subterms for cerebral infarction, myocardial infarction, and other subterms. So I would suggest that you underline cerebral and myocardium so that you can find those quickly and don't get confused and go to the wrong category. Under myocardial infarction, you might want to underline non-ST, ST, subsequent, and post-procedural, or anything else that you think will help you. Make your book work for you. Make what you need to do to help you find the correct code. In the tabular list, I would circle the code also and use additional code notes so you be sure to see them. They're easy to miss when you're in a hurry trying to code. So if you have those circled, you're more likely to see them. Make a note under I-22, subsequent within 28 days. Make a note for non-transmural subendocardial, use I-21.4. Next to type 2 to 5, the I-21.4, use these codes for initial and subsequent. And then under I-21.0 to 0.9, use for type 1 or unspecified only. That completes this lesson. If you have questions or comments, please feel free to contact me. I would love to hear from you. If you'd like a copy of these slides, just ask. Here are the ways to contact me on Facebook and my email. If you're interested in taking a look at my books, they are available on Amazon. The easiest way to find them is to go to Amazon Books and type in my last name, Tropin, T-R-O-P-I-N. Thank you so much for listening. I hope this lesson helps, and I hope to have more up soon. Thank you.